Et bonjour tout le monde. Aujourd'hui, le docteur Meller va faire une présentation sur les urgences psychiatriques. You can get started, Dr. Meller.
All right, thank you, Aisha. Hi, everyone. Happy to be here this morning and speak about emergent psychiatry. Until recently, I was assistant professor in Albert Einstein College of Medicine, and I still teach there. And as I said, today I'll speak about emergent psychiatry. And every time I speak about emergent psychiatry, I guess the first time I say is, any emergency is a medical emergency first, and before we even kind of speak about emergent psychiatry, when we see a patient in an emergent situation, they have a broad differential diagnosis. So what I'm hoping today is to really focus on alcohol withdrawal, specifically delirium tremens, and the treatment of that. The reason why I chose this topic to speak, a few reasons. One, it probably has the highest mortality rate of all psychiatric emergencies. Second, it is almost completely treatable if you diagnose it in time. And third, during these times, during pandemics, when people get sick and maybe they don't have access to alcohol, this is the times when we usually see severe alcohol withdrawal, delirium tremens. So let's go ahead and start. Dr. Sakaji, you can move on to the next slide. All right, so this is a case study to kind of flesh out what we see when it comes. So Mr. Jones is a 52-year-old male. He's a lawyer, has a history of hypertension, well-treated, and also a history of type 2 diabetes. And he presents to the hospital for an elective cholecystectomy, has some gallbladder symptoms, and have surgery to remove it. He was admitted to the unit after having spiking fevers, and the operation was really not complicated. This is what you're told when you're asked to evaluate the patient. Dr. Sakaji, could you move on to the next slide? Thank you. Now you're asked to evaluate Mr. Jones, and this is 34 hours post-operation. And the caring nurse is very concerned about Mr. Jones. He's agitated, he's tremulous, he's shaking, sweating, screaming, get these mice off of my body. He's pulling the lines and he's trying to get out of bed. His blood pressure, when, post-op was fine, all of a sudden is 180/100. And his temperature is also elevated significantly, 38.5 Celsius. Next. So first of all, a lot of times when you're being called for aggressive behavior or for various hallucinations or psychotic-like behaviors, then you move to the psychiatrist side. Well, I'm, as a psychiatrist, asking you and kind of encouraging you as residents and physicians to kind of take a step back. Wait, what's going on? Why is this patient behaving, and kind of create a broad differential diagnosis? So let's take 30 seconds, 40 seconds. You just can draw down in your mind or on a piece of paper what your differential diagnosis is, or what your differential diagnosis would be in this case.
I guess, yeah, Aisha, somebody.
Okay. So, that's the story and the context. I think, firstly, the story is very important. If the person was, I don't know if the person is alcoholism. So, if the person is not alcoholism, firstly, I will talk about the delirium. But if the person is alcoholism, I think about hallucinosis, alcohol hallucinosis, because I don't think the delirium tremens, because I think that delirium tremens you have it after 48 hours. It's like that kind of thing.
Yeah. So exactly what you're saying, you want to know what the history is. You want to know, what was that?
No,
So when you differentiate the differential diagnosis, it is so, this kind of guides you as you're asking the question, you're obtaining the history. You're right, without a history of alcohol addiction or alcoholism, as you said it, you wouldn't suspect it. But you definitely want to ask that. But as you kind of hinted, there are a lot of other things going on. This patient is post-surgery. It could be an infection. It could be a result of the surgery. It could be various other neurological issues that are going on, whether stroke, whether meningitis. It could be iatrogenic. It could be a response to another medication he's receiving. You know, about what you said about when you would expect delirium tremens, it's very tricky. Remember, this patient went into surgery. Surgery means that they use anesthesia. Anesthesia oftentimes allows a delay of withdrawal. So, and sometimes kind of there's a timeline, the statistics of when it falls. So some people may have the withdrawal sooner and some later. So the reason of keeping a wide differential diagnosis is to make sure that you ask all the things that you need, and you do the physical exam the way you need, and look for signs and symptoms to support it. We kind of hinted at, you know, at this wide differential diagnosis, and today we're going to focus on the idea of delirium tremens, of alcohol withdrawal, Dr. Psychiatry, we can go move on to the next slide.
Hello?
Dr. Psychiatry?
What do you say?
All right. And today, really, what I'm going to try to cover is a few topics regarding alcohol withdrawal and delirium tremens. The pathophysiology, how it happens. Now, for me, always, that's the best way to memory. If we understand something, then we don't need to memorize symptoms. It kind of makes sense. It's a cause and effect. So I'm hoping to review the pathophysiology in a way that you would kind of make intuitive why the symptoms are as such and why the mortality is as such. Then we'll move on to epidemiology, how it looks in the general populations, what's the incidence, what's the prevalence, what's the mortality rate. We'll move on to kind of the idea of the diagnosis. How do we make the diagnosis? What do we need to make the diagnosis? And once we made the diagnosis, what is the treatment? I'll briefly speak about comorbidity and complications of alcohol withdrawal, delirium tremens, and its sequelae and things that we would expect to see with it. And then hopefully we'll have enough time for questions if you guys have it. Right, Dr. Sakaja? Thank you. So in this image, we see a GABA channel. Now, taking a step back, we have 7 neurotransmitters in our brain. There's a little bit more amines, but 7 main ones. And these chemicals, these neurotransmitters, amines, help the neurons communicate between one another. Now, one of the main inhibitory neurotransmitter is GABA. And that is the neurotransmitter that gets activated when we ingest, when we consume alcohol. So what we see here is an ion channel. And when we consume alcohol or a medication that kind of stimulates it, what it does, it opens the GABA channel. And the GABA channel allows a negative current. A negative current basically implies that the neuron is less likely to fire, less likely to communicate. And when we think about, when we drink alcohol, we become a little bit more inhibited. Our muscles are a little bit more relaxed. Maybe we're sleepy. Sometimes, when we're intoxicated or when someone is intoxicated, there's slurred speech. So these are all symptoms of decrease of central nervous system stimulation. And kind of this is the effects of alcohol. But now let's move on to the next slide. And I'm going to talk about what happens when we have excessive drinking. So here in this slide, we see the presynaptic neuron on top. And the presynaptic neurons, they're little vesicles. These vesicles have GABA neurotransmitter, the chemical that signals the next neuron, the postsynaptic neuron. And these vesicles fuse to the synaptic synapse, and and excrete the GABA receptor, the GABA neurotransmitter that affects the postsynaptic neuron, which in turn binds to the GABA channel, and then causes this. But what happens when we drink alcohol? We basically decrease the vesicles into the synaptic cleft. And what happens when we drink a lot of alcohol? There's a lot of GABA being synthesized, a lot of GABA being secreted, and the postsynaptic cells, has this mechanism of knowing, we know there's a lot of GABA going on. Why don't we increase the amount of channels? There's too much inhibition. Why don't we increase it? And then there's the phenomenon of tolerance, which means we need more alcohol, or a patient needs more alcohol in order to get the same effect. And this is caused because of upregulation of receptors. Now, this is the key concept in developing of withdrawal and in delirium tremens. So imagine a situation where someone, let's say Mr. Jones, is drinking an excessive amount of alcohol, and it's been going on for years. All of a sudden, his brain is filled with a lot of GABA channels, and he has a lot of GABA to kind of to stimulate them. But all of a sudden, he stops drinking alcohol. He has all these channels, but very little GABA all of a sudden because he's not drinking alcohol. So all of a sudden, his brain becomes very, very stimulated because the GABA is not enough to stimulate all the channels that have been created. So this is, in short, this is kind of the story of what withdrawal, what delirium tremens is. Let's move on to the next slide. So how do we know when it's too much? Is it 1 drink? Is it 5 drinks? Is it 10 drinks a day? And what we know is statistically through the DSM. The DSM is kind of the psychiatric handbook, and it's a statistical manual. So it's taking a random sampling of a lot of people and saying, well, what happens when these symptoms occur? And what we know is that there are a few things that give us a hint that there's too much. Now, it's not that every single person who has a problem with alcohol addiction or alcoholism that is going to have every single symptom. But if they have 5 or 6 of them, then it's high suspicion that they do. So a desire and unsuccessful efforts to cut down, people kind of stop taking down. A large intake of alcohol, craving, even when they're not drinking, craving of alcohol. A decrease in functioning. Now, decrease in functioning could have a lot of ways. Am I hearing a feedback, or is it
Yeah, it's a feedback.
Okay.
Aisha, can you, I'll tell Aisha to turn, yeah.
Right. No, I just thought maybe the translator is here. But by the way, if I'm being unclear or I'm speaking too fast, then kind of raise your hand and I'll slow down, okay? Again, the desire or unsuccessful efforts to cut down, great deal of time obtaining recovery, trying to stop, craving alcohol, and decreasing functioning. And decreasing functioning, sometimes we say, oh, the person is going to work. They're able to do their main job, so they're functioning. But what I mean when I say decreased functioning, sometimes, there are a lot of important things in our lives. Whether our spiritual habits, whether our family and interpersonal relationships, whether our hobbies and things we do off time, and these are all decreasing functioning. So if all of a sudden a person who loves being with their family and friends and is interested in doing sports and loves arts, all of a sudden doesn't do any of these things, still goes to work, doesn't do any of these things because he spends most of his time drinking, that's a decrease in functioning. And I say that because a lot of times we see people who are able to kind of continue work, but aside from that, really kind of their other functioning deteriorates. Morgan, go on to the next slide, please. Dr. Sakaju, can go on to the next slide. Dr. Sakaju?
Yeah, you didn't go through the next. Hold on.
No, I see
The
uh,
PowerPoint disappeared.
Dr. Andre in front of me now.
The what?
I see
Oh,
Dr. Andre instead of my slide. It's a very, very beautiful face, but it won't help.
okay, here we go.
All right, wonderful. All right, so again, other symptoms are continued use regardless of problems. So people that their spouse is very angry with them because they're not able to do some of the household and they continue drinking. They get in trouble with the law because they're caught maybe driving their car under influence and they still use it. We spoke about giving up activities because of alcohol. The current hazardous situation, so again, repetitive car accidents, developing of tolerance. Developing of tolerance is what we discussed last time, that last slide, a couple slides ago, when they need more alcohol to achieve the same level of intoxication. And this is because of the upregulation of the GABA channels. And finally, withdrawal, meaning when we hold back the alcohol, then they start having physiological and psychological symptoms. All right, we can move on to the next. Again, just to recap, there are 11 symptoms. So patients don't need to have all 11 symptoms to kind of meet criteria. It's enough that they meet 5 of them. Now, kind of moving on from the pathophysiology and the diagnosis of alcohol addiction, we move on to the epidemiology. And by the way, all the information I obtained, or most of it regarding epidemiology, is from the World Health Organization. There was an extensive report in 2015. There hasn't been an update yet, but most of the charts are from there, and more than welcome to use my slides and my references at the end. So here you see the global distribution of alcohol. It's per capita, and the writing is very small. I can't even see it, but from my memory, it's per capita, and it is divided based on liter consumption per year. So we see the highest area is Northern Europe, but then closely behind it is North and parts of South America, following Central and Central America, Latin America, and the Caribbean islands as well. So there are extensive use. Now, this is regarding all adult population. There are specific populations that are more at risk for both consuming alcohol and developing alcohol addiction. Can we move on to the next slide, please? Right. So again, more specifically, 10 to 20% of males are heavy drinkers. So by the fact that men statistically, they're more likely to be heavy drinkers. What is heavy drinkers, you may ask? Heavy drinkers, again, this is more about statistics, is more than 2 to 3 alcoholic drinks a day. Every day, or binge drinking. I think of more than 8 drinks. What it constitutes an 8 drink, either hard liquor of 20% alcohol or more, 2 ounces of that, or beer or wine that have about 8 to 12% alcohol, and I believe it's 6 ounces, 12 ounces is considered a drink. 5% of females are heavy drinkers, and 2.5 million deaths a year are attributed to alcohol. So just to give a perspective, the global health burden, HIV and tuberculosis, together doesn't add up to 2.5 million. So this is kind of this really kind of silent killer that we relatively, as medical providers, speak little of. 4.5% of global burden of disease. So it means not only kind of the death toll, but the economic and how it affects kind of the healthcare system and a social system in general. may decrease lifespan. Chronic use and heavy drinking may decrease lifespan by 10 to 20 years. So this is kind of really a major behavior of public health concern. We can move on to the next slide. So 50% of people with alcohol use disorder will have signs and symptoms of withdrawal. And you know, regarding the first kind of statement, you know that if you're able to get the history of heavy drinking, then there's a high likelihood that there is withdrawal and possibly delirium tremens. Some patients are embarrassed by their alcohol use, or they have poor insight, meaning they don't think their alcohol use is a problem, so they may minimize it in the history taking. So you might want to collaborate with family. How many drinks? And you want, rather than asking judgmental questions like, do you drink too much? And then it's a yes/no question, asking like, how many drinks do you drink a day? Or what do you like doing in your spare time? How many days a week do you drink? Questions like that, and start getting information in a non-judgmental way to allow getting accurate information. 3 to 5% of people will have serious life-threatening sequelae of alcohol withdrawal, including seizures, delirium tremens. So out of the 50% of people that experience withdrawal, about 5% will have significant and serious symptoms. Now, let me be clear, it will probably be more than that, but most people with severe alcohol withdrawal just don't stop drinking, so they don't have alcohol withdrawal. So it's not that the 3 to 5% have you know, kind of the significant problem, but 3 to 5% is because most people don't stop drinking. Now, most importantly, kind of epidemiological alcohol withdrawal, in general, alcohol dependency also is a treatable condition, but alcohol withdrawal, which is life-threatening, is definitely treatable, and really the outcome depends on when we catch it. So let's move on to the next slide, and I'd like to share a useful, before that. So what is alcohol withdrawal? What do we see in alcohol withdrawal? And again, I mentioned there's a tool, a rating tool that I'm going to share with you guys, and I will send to Aisha a form, and I think it's very helpful to both share with your colleagues and just to have, because it gives you an objective perspective. But before we get to that, really the symptoms are insomnia. Now, I want to mention, you know, having worked in a hospital for a long time and having seen patients, a lot of these symptoms can be very ubiquitous, meaning you see them often. Not necessarily because of alcohol withdrawal, because of, you know, patient not being well and being in a hospital, like insomnia. How frequent is it for a patient to complain, I can't sleep, in a hospital, not in their own bed, and, you know, when they're not feeling well? It's pretty common. Anxiety, feeling, you know, I'm sick, I have a dread, I have worries. Again, very common for a patient to experience anxiety in a setting of a hospital or in the setting of not being well. Tachycardia, elevated heart rate. This is very important because, again, it shows activation of central nervous system. Increased respiration rate, body temperature, all of these are kind of indicators that the central nervous system is hyperactive. Part of the hyperactivity of the central nervous system allows some of the thalamic centers to be hyperactivated, and therefore they send peripheral signals to the heart and create increased blood pressure and body temperature and respiration rate. Hand tremor, fine hand tremor, is something that we often see. What is usually useful is to kind of have a clinical picture before these symptoms came about and after they came about, because some people have a continuous tremor as part of an ongoing neurological symptom like Parkinson. But in acute, all these things happen acutely. So oftentimes you're being called after you're already seeing the symptoms, and therefore it's really important to kind of to speak to the physicians who are treating them and see how the presentation changed. We can go on to the next slide. So symptoms of withdrawal initiate within 8 hours. And again, Mr. Jones before, it really happened after, I think I mentioned there 34 hours or 40 or 40-something hours. But symptoms really start after 8 hours. But this is an important piece, that this is a continuum, meaning it's not a binary system where it exists and it doesn't exist. It slowly progresses. So in the beginning, it's very ubiquitous, but then it progresses and exacerbates. So the first symptoms are within 8 hours, but then later kind of they really peak within 72 hours of no alcohol. Now, I want to mention something that I briefly mentioned before. Oftentimes when patients come to the hospital, we're treating them with medications that synergize alcohol or can replace alcohol. An example, Versed is used in anesthesia oftentimes and activates the GABA receptor. So a lot of times you might look at the time and date of admission, where in fact a day after that they received some medication that allowed the delay of symptoms of withdrawal. So it's important to kind of keep that in mind. And after 5 to 7 days, it's really reduced events. Another thing, oftentimes chronic alcohol users have impairment in their liver. And what that entails means that they break down alcohol a lot slower, meaning the alcohol stays in their system a lot longer. So this can impact the time when the withdrawal starts. If there are any questions at the end, I'll be happy to answer about that. But these are kind of the mild and moderate withdrawals and some things to keep in mind. Let's move on to the next slide. All right, so this is the CIWA scale, which stands for Clinical Institute of Withdrawal of Alcohol. And this is a way that that you can objectively assess the symptoms of alcohol withdrawal and know what you're facing with. You could also repetitively do it and know if the treatment that you're providing for the patient is adequate treatment. And you can see if the symptoms are kind of on a downtick or on an uptick. So this is a scale that I find is very, very useful. It's very easy to implement. It doesn't involve a lot of questions to the patient because sometimes their sensorium and then mentation could be impaired. And it's relatively quick. Sometimes ancillary staff, nurses, and other ancillary staff can be helpful as well in obtaining that. And again, it can guide treatment. So I won't go into that, but I will pass along this form so you guys can get it. And again, it goes through some of the symptoms that I mentioned previously. Okay, we can move on to the next slide. And it's a point system, so I think 67 or 70 is the highest level, and if it's above 17 or 20, then you know that this is a very serious, kind of going to a serious withdrawal. So what is delirium tremens? What is the difference between delirium tremens and withdrawal? Again, this is a continuum, so it's not necessarily kind of a point, but the rapid fluctuation of disturbance of attention and cognition with or without hallucination, along with alcohol withdrawal, is the definition of delirium tremens. So basically, seeing alcohol withdrawal and the patient is confused, the patient is disoriented, the patient is distracted. This can be with hallucinations, much like Mr. Jones had, or it could be without it. Again, it's kind of the squeaky wheel gets the oil. Often the quiet patients who are more confused and don't voice are ones that you miss. So it's important to note that it doesn't necessarily need to have a hallucination. Dr. Psychiatry, we can move on. So what is the prognosis of DTs? We've identified alcohol withdrawal, we've identified DTs. We know that there's, with treatment, there's a 1 to 4% mortality of hospitalized patients with DTs. The cause of death usually is due to hyperthermia. And again, this is hyperactivation of the central nervous system that leads to hyperthermia. Cardiac arrhythmia because of increased stimulation of central nervous system to the heart, it causes arrhythmias. Withdrawal seizures, because there's a hyperactivation of the central nervous system, it could start to generate seizures. And then there are exacerbation of concomitant medical disorders that could lead to that. Again, 1.4%, I said this is a treatable disease. Just to be clear, without intervention, someone with DTs, it's about a 40 to 50% death rate. So treatment decreases mortality by a lot. Also saying DTs is oftentimes preventable if severe withdrawal is noticeable in the first hour. So the 1 to 4% could decrease to close to 0% mortality if this is caught in time. All right, we can move on to the next slide. So some predictors of alcohol withdrawal. When should you be more concerned? When should you be an even closer eye on DTs? So CIWA, that's again the tool that I used. There are a lot of studies showing that a score of above 15 indicates at poor prognosis, and you should be very kind of concerned. I'm sorry, I misspoke. These are predictors of DTs, meaning who from the alcohol withdrawal will develop DTs. And if CIWA point system, you get more than 15, you should be very concerned that this patient may develop DTs and be very hypervigilant about the patient's care. A systolic blood pressure above 150, a heart rate above 100, recent withdrawal seizures, so if there are already seizures even kind of before that, or a history of DTs, this patient was known to have DTs, delirium tremens, in the past. The age of the patient, with increasing age, meaning the longevity of alcohol use, there's an increased risk in delirium tremens. And then finally, concomitant medical problems. If there are other medical problems, diabetes, liver failure, that all gives increase for developing delirium tremens from alcohol withdrawal. Let's move on to the next slide. So really, the goals of treatment, once we identify and understand the risks, is A, to decrease mortality, because there is treatment and the treatment is effective and we can save these patients' lives. There's a decrease in system injury. So when a patient has DTs, it could cause dysfunction of liver dysfunction, kidney dysfunction, other system dysfunction, and therefore treating and preventing DTs really allows us to allow other areas of health to not to exacerbate and deteriorate. We want to decrease seizures because, again, that is one of the causes of the mortality rate. And we want to control agitation, make sure that, that the patient is safe, make sure that the medical staff is safe, make sure that the other patients surrounding are safe. These are all the primary goals of treatment of delirium tremens. Let's move on. So kind of having in mind, once DTs is identified, we want to admit to an inpatient unit or to ICU. We're talking about admitting and having the patient observed very closely. If there's no access to ICU because the ICU is full or because it isn't available in the facility, then just making sure that medical personnel are really observing because things can deteriorate very quickly. Workup during this time, the initial time workup of co-occurring illnesses. We want to make sure this patient doesn't have liver failure, that we take labs and rule out other infections that may cause similar symptoms, rule out any other neurological conditions that may require treatment, and kind of generate a broad differential diagnosis to allow us to kind of look for these other things and rule them out. In the meantime, we can, as we're doing this, we can kind of continue with the IV hydration, because again, hyperthermia is one of the causes of death. We want to make sure that the patient is well hydrated. Thiamine, I'll speak a little bit about thiamine deficiency in alcohol at the end, We want to give thiamine with the IV hydration. We want to give thiamine with glucose. Again, I'll speak about it a little bit later. And we want to provide, if again we identified alcohol withdrawal, we want to provide benzodiazepines because that really kind of decreases the likelihood of developing delirium tremens from severe alcohol withdrawal. And it's the primary mode of treatment for delirium tremens itself. Now, this could be sometimes kind of scary because a patient's mentation can be altered. Someone can be disoriented, not know where they are, and then you're giving them a benzodiazepine, and yet recognizing and following this algorithm is really important. Again, the benzodiazepine is the primary mode to prevent seizures and treat DTs. Let's move on. All right, so which benzodiazepines do we use for treating DTs? And oftentimes different hospitals have different things available, different medications, different benzodiazepines available to them. Whatever benzodiazepine is available when you're treating a patient with alcohol withdrawal and delirium tremens, it's important to remember two aspects about benzodiazepines. They vary in the length of action, their half-life. For instance, Valium has a very long half-life, 20 to 50 hours. To midazolam, which is the Versed, which is used for oftentimes for anesthesia when we intubate patients, and that half-life is very short, 1 to 6 hours. That's one thing, the longevity, the half-life of the medication. The other part that varies in benzodiazepine is the amount of time it takes for them to have an effect. Again, there could be medication that has a long half-life, and it becomes, it works very quickly, or there could be a medication that has a short half-life and it takes a long time for it a relatively long time for it. Now, what we're aiming for is a medication that won't, that would have a medium half-life, something like Ativan, that's like 8 to 10 hours. But we'll start working immediately. This patient is in an emergent condition. We want to make sure that that we're kind of targeting those GABA receptors sooner. So those are the two things that we look at when we find the right benzodiazepines. Montefiore, the clinical hospital of Albert Einstein College of Medicine, usually uses Librium and Ativan, lorazepam and chlorodiazepoxide. Most studies also mention these two medications, but Valium, diazepam has been studied as well as others. The other thing that I'm going to speak in the next slide is how is the benzodiazepine broken down? And let's move on to the next slide. And really, most of the benzodiazepines have a two-step pathway of breaking down, meaning they get into the blood system, they're broken down by the liver, and then they're continued broken down and secreted by the kidney. Now, a person with chronic alcohol use, sometimes their liver is not functioning properly. And what this means is that you're lengthening the half-life of the medication. The medication can't be broken down by the liver, it can't be secreted by the kidney. And then you have, let's say, Valium that lasts 20 to 50 hours, all of a sudden lasts 100 hours. So you want to be careful with longer half-lives and with medications that are metabolized in the liver. Now, there are 3 benzodiazepines that are not metabolized in the liver. The first is lorazepam, the second is oxazepam, and the third is temazepam. We have access to lorazepam, which the brand name is usually Ativan. And so this is another reason why I like using lorazepam. If there is liver disease, then we can kind of bypass that. Let's go on to the next slide. Before I speak about this, I just want to be clear. I'm not mentioning doses of benzodiazepines for a few reasons. One, I don't know which benzodiazepines you guys will have, and they differ kind of in terms of the dosing. 2, oftentimes they require very high doses, higher than recommended. This is because of a few things. A, these patients develop tolerance to GABA-producing substances that synergize the GABA system. Remember that one of the first slides was showing how there are a lot more receptors, and therefore, we need a lot more medications to have an effect, a lot more synergy to GABA. Second, a lot of times they're clinically informed, and what I mean by that is you give a dose of benzodiazepine and you reassess in an hour. How is the heart rate? How is the respiration rate? How is the CIWA score? Has it improved? It's not improved. Let's give more. So a lot of times I don't do it necessarily by body weight. I don't do it necessarily by a standard. I leave a flexibility to come see how the patient is responding to the treatment. So a non-benzodiazepine for DTs, and the most important part here is what not to do. But before then, I guess phenobarbital. There are some studies showing that phenobarbital could be useful, and propofol. When you reach the state of treating with phenobarbital and propofol, then you want the patients to be in ICU. You want to be in a place where you're probably going to intubate the patient because of increased risk. But there have been studies utilizing these medications, basically putting the patient in anesthesia to kind of prevent seizures and further exacerbations. What you want to avoid with alcohol, severe alcohol withdrawals and delirium tremens, antipsychotics. So oftentimes patients become agitated, and then you want to give maybe Haldol or something. It actually, I don't know, I'm not going to speak too much about this, but actually neuroleptic syndrome is something that they're more likely to get during alcohol withdrawal. Neuroleptic syndrome is, again, an excitability of the central nervous system that leads to hyperthermia. So you want to avoid antipsychotics for that reason. Anticonvulsants, you see a seizure, you're saying, oh, let's treat it with an anticonvulsant because of the seizures. Again, rather than a focal seizure, this is a central nervous activation, and therefore sometimes it can exacerbate various metabolic things that are going on. Also, the liver may not be functioning, and therefore these medications may not be secreted and could end up being toxic. So avoid using anticonvulsants. Use benzodiazepines to control seizures. Centrally acting alpha-2 agonists. A lot of times in withdrawal from opiates, from other substances, we give clonidine and other alpha agonists to control the shaking, some of the withdrawal symptoms. Do not do this in this case. Again, it could, has been shown to not only not be helpful, but cause increase in morbidity and mortality. Beta blockers, again, you want to avoid for the same reason. And baclofen, you might see, the patient is tense. Let's relax the muscles. Similar to what I just said, it can increase morbidity and mortality. So really, close monitoring benzodiazepines are the major treatments. Pretty simple, but you got to be on top of it in terms of the dosing and the repetitive dosing of it. Let's go on to the next slide. Okay, related disorder. I can give an entire lecture on each one of these related disorder, but just important to kind of remember and think about when someone has DTs, has severe alcohol withdrawal, you want to think of Wernicke encephalopathy. And this, as I said, will come back to the thiamine deficiency. Thiamine is B1, is central to building of myelin, the sheath around the neurons. Thiamine is also stored in the body for we have access stores of about 3 weeks. If someone drinks very heavily, their nutrition may not be appropriate. Thiamine is also used, B1 is also used to synthesize GABA. So if we have someone who is drinking alcohol and their GABA system is very activated, the consumption of GABA, the consumption of thiamine is going to be depleted sooner. Once thiamine is depleted, then we can have Wernicke encephalopathy, which affects various areas in the brain and creates this triad of ophthalmoplegia, which is the muscles of the eyes, that they become weak and ineffective. And this usually presents in terms of nystagmus. the rotating of the flickering of the eye. It also presents with ataxia, cerebellar dysfunction, which, if you remember from your anatomy or pathophysiology or neurology rotation, causes kind of impairment maybe in walking and coordination. So again, we're talking about ophthalmoplegia, which you can easily do a physical exam and look for nystagmus. You're looking for cerebellar dysfunction, wide-based gait, and coordination. So touching a finger and nose would be a physical exam, and they're unable to do that. Orientation. So being disoriented, or their mental status is impaired. Oftentimes it's confusion or lack of attention that is affected. And you can check that by asking them to repeat a number back to you, or asking them to repeat a 4-digit number back to you reverse. So I say 1, 2, 3. The patient says 4, 3, 2, 1. 1, 2, 3, 4, 4, 3, 2, 1. That's a way to test attention, and sometimes a way to test for it early on. So this is Wernicke encephalopathy, and again, the great thing, there's nothing great about Wernicke encephalopathy, but catching it early allows us to give thiamine with glucose, and it could be reversible. Chronically, it can cause Wernicke-Korsakoff, which involves not only the symptoms that I mentioned, but confabulation. So really the memory starts being impaired, and we start kind of like making up stories. Thiamine-related cardiomyopathies, again, I said, myelin sheaths and other organs are involved in B1, and it could cause cardiomyopathy. Liver cirrhosis are other things to keep in mind as adjacent pathologies that may be comorbid with severe alcohol use. All right, Dr. Psychiatry, can we move on? I think we're almost done. Yes. All right, I'm sorry, I know it's 9, but if there are any questions, I can stay for additional time. I'd also be happy to kind of get questions to Aisha, Emil, or Sarah.
Si on a des questions, peut-être vous pouvez la poser ou bien l'écrire.
Okay. Yeah, I have one question. Hello?
Yes.
Oui, vous parlez, oui.
Yeah. Okay. My question is, I want to know if there is some ethnic group that are more sensitive to alcohol withdrawal or delirium tremens than others.
All right, it's a very, very good question. So most of the studies are actually about sensitivity to alcohol breakdown. So there are certain ethnic groups, both Central Asian subgroups that are more sensitive to alcohol, and the breakdown of alcohol is slower. This causes alcohol intoxication more easily, syndromes of flushing. Strangely enough, or not strangely enough, this is actually protective because the act of drinking is so aversive, it makes them feel so bad and sick, and they usually kind of have GI symptoms, and they usually don't develop addiction, and there's less incidence of withdrawal and delirium tremens. I know you're asking about the opposite, ethnic groups that are more likely. I'm not aware of any ethnic groups that are more likely to develop. We do know, and this has nothing to do, as far as I know, that there are no genetic predisposition for alcohol withdrawal. There are cultural factors that involve drinking and increased amounts of drinking. Then we see the incidence of delirium tremens and alcohol withdrawal, and in general alcohol addiction increase. We do have some genetic data about predisposition of addiction. So if there is a family member that has an addiction disorder, especially if it's a direct relationship like a sibling or a parent, then there is an increase, a 4 to 10 time increased risk for an addiction disorder in that individual. Again, I know you asked about more ethnic groups that are more predisposed. And I'm answering about specific families, but those are the studies I'm aware. I will look at specifically ethnic groups that are more predisposed to it and to alcohol withdrawal and delirium tremens, and I'll get back to Aisha if I find something, or if I don't find anything as well. Are there? I'd be happy to answer any other questions if there are.
Hello?
I'm still here.
Yeah. I got another question.